So let's go to the second round of discussion, and I'm going back to my patient. So it's rituximab VRd. She is relapsing, and it looks like that, for instance, based on what Martin mentioned, one option would be to use one of the belantamab-based combination. And here I'd like to quote, it's not me, Dr. Jesus San Miguel at COMI in May 2024, who said, well, how am I going to choose between CAR T cells, belantamab, etc.? 36 months median PFS in DREAM7, I think he said, will make me think whether I should give CAR T cell or something else. So what do you think?
Yeah, absolutely. I mean, I think the first point to say is that the first relapse situation for a patient is a very important time in their myeloma journey. Your patient had an extremely good response to the quadruplet, and you can see that they presumably had a very good quality of life, because when they've relapsed, they've remained to be fit. And so the second relapse is a very important time, because again, the data, particularly with Bela-VD, showing a 36-month PFS, will allow that patient to enjoy a long quality of life. As you see, as time goes on, you get that attrition and you get the comorbidities appearing and patients' quality of life deteriorates. So I think it's very important to go for that. And I think the belantamab combinations clearly allow good quality of life, because the dosing of belantamab can be infrequent. So it can be 8 weekly dosing, and stepping down to 12 weekly dosing is what nowadays we would recommend. And that really does limit the patient from coming to hospital. And more importantly, it limits the ocular toxicity that Martin showed. You can really bring that down to simply grade 1, maximum grade 2 levels, and remove the grade 3 indication. So I think that works well.
Wonderful. So here we have a case discussion for you guys. And this is a 67-year-old male, multiple myeloma, standard risk, transplant eligible, got VRd, auto-transplant, maintenance with LEN, and you can read the second line current therapy. Belantamab, bortezomib, dexamethasone, like in DREAM7. So Martin, I would kindly ask you about the primary concerns for this patient who has some visual acuity changes, dry eyes, photophobia. What do you think?
Well, I mean, I assume that the patient probably has started the treatment as per the data that has been generated from the trial, so effectively with in this case, bortezomib 3 weekly dosing of the belantamab. And I think this is really coming back. I have to say it has helped me a lot with managing my patients, and I think it has really been very consistently working as well. When you really make yourself clear that the eye just needs longer to regenerate necessarily than the 3 weeks that were tested in the trial, we are facing a drug that has really excellent efficacy, as we have seen in 2 trials now with very, very purist design, if you probably give the eye just more time to regenerate. So I would say this patient, the acuity changes very likely are a symptom of corneal incorporation of belamaf and probably some inclusion bodies. They will grow out. I think we just need to give the eye more time. They will grow out. We should, in the meantime, of course, encourage the patient to keep good eye hygiene and eye drops, etc. I don't think that any other specific intervention has proven any further, benefit there. It's just giving it time, and it will grow out, as we have seen in the trial, and we have seen in our clinics many times as well. And then it's mostly finding the right interval of dosing with the patient, in my view. If it's relatively low acuity changes as here, the likelihood that they will resolve completely is very, very high. And it's also very likely that we can find a dose with less frequent dosing. And I would agree, it's at least probably 8 weekly, 6 weekly dosing, 8 weekly dosing. It could even be more in the combination therapy. I think we need to learn probably a little bit more about this still. I would still personally favor a lot, more trials in this area to really find the right dose, but in a clean fashion. But there's definitely a way to find a dosing, in my view, that the patient will long-term tolerate.
Excellent. So let me ask our audience, how would you treat, well, obviously Martin shared with you his view, how would you treat the visual acuity changes in this patient? You're going to forbid the use of eye drops? I hope not. Encourage the use of contact? Okay. Superb. I think the message was delivered. Fantastic.
Yeah.
Superb. Reduce the frequency of belantamab. And this is what's making it very convenient, because you have at the same time convenience and efficacy. So let's continue our discussion. And I have here a couple of questions from the audience. Rakesh, I think you have used a lot belantamab, and you pioneered some of these scales and evaluations. Do any patient factors influence the incidence of ocular toxicities with belantamab?
Yeah, it's an interesting concept. So the first thing we realize is that patients with relapsed myeloma do not have normal eyes, and many of them do not have normal corneas, and that's because of the treatments that we've given to patients, particularly dexamethasone, which causes cataract formation, and other treatments that can impair visual acuity. So you do need to look after your patient's eyes. You need to reduce the dex. So we have this down the dex motto that's going on. I think it's very important to make sure that good eye health is preserved throughout the patient journey. What we find when we correlate baseline ocular assessments and the incidence of keratopathy, that the presence of dry eyes and low-grade keratopathy to begin with does predict for worse-grade keratopathy. So on your baseline ocular exam, just make sure you're looking for those and increase the frequency of lubricating eye drops if your patient is at risk of dry eye.
Excellent. Thank you very much. Any thoughts, any tricks from the audience if you are facing ocular toxicities, keratitis? I have another question here, Martin, for you, because you described nicely in these beautiful curves of the DREAM 7 and DREAM 8. And the question, how would you choose between these two regimens? What are the criteria? And I think Rakesh mentioned regarding my patient that usually patients are not refractory to bortezomib. They are exposed. So this combination of Bela plus bortezomib is very attractive, because actually you're using a drug that we know since many years. It's a generic. But again, the oral drug pomalidomide is also quite attractive. So how does it work in your practice?
I mean, you already mentioned, of course, the previous therapies, and I agree most patients are probably not refractory, to either of the drug or either of the combination partners. I think there is, of course, something I would love to see is longer follow-up, because we have not seen the median progression-free survival being reached with the pomalidomide combination yet. We don't know yet. It might really be strikingly longer, and we might actually be having that as an important factor to consider when choosing between the two regimens. It wouldn't necessarily surprise me that much, because of course we have to consider that in DREAM 7, like in DVD, the bortezomib duration is limited. So at some point we're going back to the single agent drug. And you can see that as a pro and a con. You can see it as a positive, because especially if we think about longer dosing, that would really mean from that time point onwards, patients are coming to hospital very infrequently and have actually outside of the belantamab no other drug that they're on. Whereas in the other combination, of course, we would still keep the combination with pomalidomide going. It might have the benefit of a longer duration of response and PFS. But of course, it will still mean more medications for the patient to take. I think there's, of course, toxicities or conditions, pre-existing polyneuropathy, that would probably advise more towards the pomalidomide regimen, or on the other hand, if a patient is more prone to cytopenias, then maybe tending more towards the bortezomib combination, because as we know, pomalidomide can still cause cytopenias. That will drive that decision as well.
Yeah, I was just going to add that in the DREAM 7 trial, there wasn't a high proportion of DARA and LEN refractory patients in them. The DREAM 8 trial had a much higher proportion of DARA or CD38 and LEN refractoriness, which is your patient. And so the data probably supports the POM combination for this type of patient slightly better. Right.
So since you're mentioning the DARA, I think at some point Dr. Tepos presented some data about using belantamab frontline. I know it's a future. What kind of other combination one can envision with belantamab, Rakesh?
So it's interesting you say that because, again, at IMS in Rio, there was data of Bela VRD, which was presented, and there's very high response rates and high MRD negativity rates as induction prior to a transplant and then consolidation and maintenance thereafter. So I think for frontline, I mean, there's certainly Bela RD, Bela RVD combinations can be used, and there are some Bela carfilzomib combinations underway as well. So, I mean, most of these are acceptable.
So going back to my patient, and I think we have a question about this. From a practical point of view, if you decide to do Bela VD for this patient who is triple exposed, what is your prescription? So would you start immediately, like every 2 or 3 months, or you would do sort of an induction phase and then sort of a maintenance long term? How do you do it practically?
Yeah. So we're actually about to open a study in the UK doing this, and basically what we're going to do is we're going to go, the belantamab is going to be Q8. We start at a dose of 2.5 to get good myeloma disease control, and then automatically stepping down to 1.9. And once you completed 6 months, then you go into maintenance with Bela every 12 weeks. That's my recommendation.